Treatment of multidrug resistant organisms, Part 1. What do you do when bacterial growth shows resistance to all of the antibiotics on your micropanel? Then what? This is the dilemma that we are faced with every day when it comes to multidrug resistant organisms. As microorganisms are exposed to common antibiotics due to overuse, they instinctually build up resistance to them, rendering the antibiotics that we use today ineffective for tomorrow's use. In this two-part series on multidrug resistant organisms, we will examine the major organisms causing this worldwide problem and the new therapies being used to combat them. As you can see in this slide, the development of resistance has been going on for many years, ever since penicillin was first developed. Some key organisms that became resistant include Staph aureus to methicillin and Enterococcus to vancomycin, both of which we previously discussed in the antibiotics module. Luckily for us, new antibiotics have and are being developed to effectively treat these types of resistant organisms, but it is an ongoing challenge. Each year in the United States, antibiotic-resistant bacteria and fungi cause an estimated 2.8 million infections and over 35,000 deaths. When we add on Clostridioides difficile, which is related to antibiotic use and antibiotic resistance, we get almost 50,000 deaths per year in the United States. What are these multidrug resistant organisms? Well, we're going to be focusing on 4 that are gram-negative. The first one is called ESBL-E, or extended spectrum beta-lactamase Enterobacteriaceae. The Enterobacteriaceae are a group of enteric gram-negative bacilli found in the colon that includes E. coli, Klebsiella, Proteus, Enterobacter, Citrobacter, Providencia, Morganella, and Serratia. The next group of multidrug resistant organisms we're going to be talking about is CRE. CRE is carbapenem resistant Enterobacteriaceae. CRE is also called KPC, which is the enzyme that it most frequently secretes, called Klebsiella pneumonia carbapenemase. The third group of multidrug resistant organisms we'll be talking about is extremely drug resistant Pseudomonas aeruginosa, an organism that is only sensitive to a few antibiotics. And finally, the fourth multidrug resistant organisms we'll complete with is Acinetobacter baumannii. The CDC also lists these 4 bacteria on their threat list. You can see that Acinetobacter and CRE are on their urgent threats list, whereas extended spectrum beta-lactamase ESBL producing Enterobacteriaceae and multidrug resistant Pseudomonas aeruginosa are on their serious threats list. So how do bacteria develop resistance? Let's go over some of the key mechanisms. The first way is through enzymatic inactivation, which is the most common mechanism. Bacteria produce and secrete enzymes that destroy the antibiotic. The second way is through decreased permeability. Pathways that are typically used for cellular entry are blocked, preventing antibiotics from reaching the bacterial target site. Efflux pump. Antibiotics are pushed across the membrane and out of the bacterial cell via active transport. Antibiotic binding. The bacteria produce alternative inactive decoy sites that absorb available drug, preventing target site activation. And target site alteration. The bacteria makes conformational changes in the antibiotic target site to greatly reduce or eliminate binding. The rising threat of antibiotic resistance is not just one hospital's problem or one nursing home's problem, but it's a community-wide problem. As you can see in this diagram, everything is interconnected when it comes to the spread of multidrug resistant organisms, going to and from different hospitals, nursing homes, and long-term acute care facilities, or LTACs. Here's a list of risk factors that may lead to the development of a multidrug resistant infection. prolonged exposures to healthcare, such as ICU and hospital stay or LTAC stay, residence in a long-term care or nursing facility, antimicrobial use within the previous 90 days, invasive or indwelling devices, immunosuppression, chronic dialysis, or home wound care. I've provided a list of common beta-lactamases that multidrug resistant organisms produce. This is for your information. Sometimes specific resistant bacteria are known by their genetic name, which can be seen in the third column. Based on the resistance genes, you can predict which antibiotics the bacteria will be resistant to. In addition to MRSA and VRE, the CDC now recognizes the development of ESBLs in 1983 and CRE-KPC in 1996. Let's first talk a little bit about ESBL-Es. ESBL-E stands for Extended Spectrum Beta-Lactamase Producing Enterobacteriaceae. Infections with ESBL-producing organisms are prevalent worldwide and are associated with poor outcomes. ESBL stands for Extended Spectrum Beta-Lactamase. It's an enzyme that's found in some strains of bacteria called Enterobacteriaceae. The Enterobacteriaceae are a group of enteric gram-negative bacilli found in the colon that includes E. coli, Klebsiella, Proteus, Enterobacter, Citrobacter, Providencia, Morganella, and Serratia. ESBL-producing bacteria are resistant to the beta-lactam antibiotics, penicillins, cephalosporins, and aztreonam. Due to resistance to most beta-lactam antibiotics, ESBL infections need to be treated with carbapenems. For bloodstream, lung, intra-abdominal, or soft tissue infections occurring outside of the urinary tract, ESBL-E infections can be treated with a carbapenem, either ertapenem, imipenem, or meropenem. We want to avoid using piperacillin tazobactam and cefepime, even if the in vitro sensitivity is documented. MIC testing may be inaccurate when ESBL enzymes are present. Once the infection is stabilized, and only if susceptible and clinically appropriate, we can switch the carbapenem to an oral step-down antibiotic, either ciprofloxacin or levofloxacin, or trimethoprim sulfamethoxazole. For pyelonephritis and complicated urinary tract infections, the drug of choice for ESBL-E are carbapenems, ciprofloxacin or levofloxacin, or trimethoprim sulfamethoxazole. We need to avoid using nitrofurantoin and oral fosfomycin because they both achieve poor upper urinary tract concentrations. And doxycycline is not cleared in the urine, so it's not indicated here. For uncomplicated cystitis, the drugs of choice are either nitrofurantoin or trimethoprim sulfamethoxazole. We can use carbapenems or quinolone in these cases, but we want to save them for the other indications. Carbapenem-resistant Enterobacteriaceae bacteria produce an enzyme called carbapenemase. Carbapenemases hydrolyze all beta-lactam antibiotics, so penicillins, cephalosporins, aztreonam, and carbapenems are not effective against CRE. The most common carbapenemase is KPC, or Klebsiella pneumoniae carbapenemase. KPC was discovered in 2001 in North Carolina and later spread to Europe in 2005. Now 9 variants of the KPC enzyme are described. It's often extremely drug resistant, and it can be produced by Enterobacteriaceae other than Klebsiella. Due to the extreme resistance to all beta-lactam antibiotics, CRE infections need to be treated with combinations of current antibiotics and beta-lactamase inhibitors. For bloodstream, lung, intra-abdominal, or soft tissue infections occurring outside of the urinary tract, the drugs of choice for CRE are ceftazidime avibactam, meropenem vaborbactam, or imipenem cilastatin relebactam. you can see that the avibactam, vaborbactam, and relebactam are beta-lactamase inhibitors that are attached to commonly used antibiotics. Let's go over each one of these antibiotics individually. Ceftazidime avibactam, or Avicaz, was approved in 2015. The dose is 2.5 grams every 8 hours, and we administer it over 2 hours. The vial size is 2.5 grams, which consists of ceftazidime 2 grams and avibactam 0.5 grams. It's FDA approved for complicated intra-abdominal infections along with metronidazole, complicated UTI including pyelonephritis, and hospital-acquired pneumonia, ventilator-associated pneumonia. We need to adjust the dose for renal insufficiency, and the daily cost of therapy is $1,000 per day. Meropenem vaborbactam, or Vabomere, was approved in 2017. The dose is 4 grams every 8 hours by infusion over 3 hours. It's available as a 2-gram vial, which consists of meropenem 1 gram and 1 gram of vaborbactam. It's FDA approved for complicated UTI, including pyelonephritis. We need to adjust the dose for renal insufficiency. There's a drug interaction, and so with valproic acid and divalproex, so it's not recommended to be used together with these two medications. The meropenem vaborbactam will reduce the concentration of valproic acid. The daily cost of this medication is $1,000 a day. Finally, imipenem cilastatin relebactam, or Ricarbrio, was approved in July of 2019. The dose is 1.25 grams IV piggyback every 6 hours, and we give this over 30 minutes. It's available as a 1.25 gram vial, which consists of 500 milligrams of imipenem, 500 milligrams of cilastatin, and 250 milligrams of relebactam. Cilastatin is a renal dehydropeptidase inhibitor. The FDA-approved indications are complicated intra-abdominal infections, complicated urinary tract infections, including pyelonephritis, and hospital-acquired pneumonia, ventilator-associated pneumonia, which was approved in June of 2020. We need to adjust the dose for renal insufficiency, and as we know in the past, seizures have occurred with imipenem cilastatin use. This drug also needs to be avoided when used with valproic acid, divalproex, or ganciclovir, as generalized seizures have been reported. The drug may decrease valproic acid levels. Also, Ricarbrio is incompatible with propofol, so it can't be given in the same line as propofol. The cost is approximately $1,000 per day. So all three medications can be used against CRE, but the preferred agent is ceftazidime avibactam because there's no concern about a 3-hour infusion and there's no concern about the drug interaction with valproic acid or divalproex. For intra-abdominal infections of CRE, it's recommended that we administer a tetracycline such as tigecycline or eravacycline. Eravacycline, or Zerava, is an extended-spectrum tetracycline that was approved in August of 2018. The dose is 1 milligram per kilogram every 12 hours, given over 60 minutes. It's FDA approved for complicated intra-abdominal infections. It's not indicated for treatment of complicated urinary tract infections because eravacycline is not renally excreted. We need to increase the dose of eravacycline when it's used with strong CYP3A inducers. No dosage reduction for all renal or liver impairments, except severe hepatic impairment, where we need to use a reduced dose. Infusion site reactions occur at a rate of about 8%, and the cost of eravacycline is about $50 per vial, which equates to $200 per day. That's all for today. We'll continue our discussion on pyelonephritis and complicated urinary tract infections caused by CRE in our next installment. In part 2 of this 2-part series, we will continue our discussion of multidrug resistant organisms, and talk about extremely drug-resistant Pseudomonas and Acinetobacter, and go over some of the newer antibiotics used in their treatment. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.